Good morning, APAO and AIOS. Perioperative medications in phacoemulsification. Well, I cannot have any financial interest because the topic that I am talking is as delicate. Well, we cannot, when we are using premium IOLs, afford infection. We have zero tolerance towards it. We need good inflammation control. We need good anesthesia. We need to see well. And we need to deal with comorbid situations, and we need medications to improve our surgical efficiency. Well, the incidence varies from as much as 1 in 4,000 to about 400, 1 in 400. With clear corneal phacoemulsification, there was a rise in the incidence of endophthalmitis, but with the fourth generation fluoroquinolones, it came down to 0.05%. Povidone iodine also gives us very good results and is perhaps the most consistent way to sterilize the conjunctiva, and both Moxie and Gatti have similar effects. However, we use it in conjunction, but an additive effect is not reported in literature. Painting the lids with 10% povidone iodine is good practice, careful draping, but this does not prevent and bacterial contamination at the anterior chamber at the end of surgery, though happens, is not very well elaborated in literature for obvious reasons. Well, we shouldn't be introducing infections during surgery, and hand wash. All marketed seal product can be re-etioed to ensure that any pricks or breaks in the packaging does not disturb the sterilization, vacuum autoclaving. And of course, the commonest offender in any outbreak of endophthalmitis in India is the irrigating fluid, and we are hardly pressed for a reliable manufacturer. However, the Alcon Baxter BSS for intraocular use is a welcome relief. Well, let's talk a little bit about the kill of the intracameral injection. The Swedish study prompted this in 2002, and which brought down the incidence of endophthalmitis to 0.6 by an injection of cefuroxime intracamerally. Then the landmark European study, which also had intracameral cefuroxime, bringing the incidence down from 0.2 to 0.02. And then Arshinov reported in a mega multi-center study, of which VV Disha Eye Hospital is also a part, and showed that the incidence dropped down to as low as 1 in 35,000, 0.003% with intracameral preservative-free moxifloxacillin 0.1 ml of 0.5% of Vigamox eye drop manufactured by Alcon, Texas. Reconstitution of cefuroxime and vancomycin may be cumbersome, and variations in concentrations may lead to TAS, so moxifloxacin remains a good alternative and a convenient one. Arshinov in the same study thought that bilateral sequential cataract surgery could be safe, because that's what we don't do because of fear of infection. In our hospital, we had one endophthalmitis last year among the 32,000 cataract surgeries that we did with the use of intracameral moxifloxacillin. 85% of the US doctors also agreed to use, except for the FDA problems. Of course, so far so good. We must realize that fluoroquinolones are very sensitive to MRSA, and the EVS group reports that 9%, the second highest preponderance is of Staph aureus. So another fluoroquinolone, basifloxacillin, which is new. It is non-systemic. It has not got any systemic use, and it's without any agricultural or animal use. So we need to evaluate. Well, we have to see these drops going into 7 to 10 days post-operatively, stromal hydration to prevent any ingress, and in event of any disproportionate AC reaction, observation on an hourly basis, and if reactions increase, we have to give intravitreal injections at the first opportunity, even before referring to a vitreoretinal center. Well, dexamethasone and prednisolone gives adequate inflammatory control, not that we introduce too much in the phacoemulsification nowadays. Bromphenic and nepofenic may substitute topical steroids after the 7th day and reduce the incidence of steroid-induced glaucoma. But with the price control of steroids in India by our Drug Authority of India, the quality of these drops in India has become circumspect, and cycloplegics need to be added in the first 5 to 7 days. That's been our experience. And of course, for the same reason, using NSAIDs from day one have been found beneficial by some other surgeons. Well, in post-operative uveitis, we can give loading oral steroids or Kenacort pre-op before surgery, and cataract surgery preferably done in the quiescent period. Topical atropine be given 3 weeks post-op, and in pediatric cataracts, if the vitrectomy is performed with triamcinolone assistance, it helps in inflammation control together with cycloplegics. And in post-herpetic keratitis cataract surgery, we need to give 800 milligram acyclovir 1 month prior and continue it into 3 months post-surgery. Well, in a meta-analysis published in Ophthalmology 2012 says that lignocaine 2% with intracameral injections give adequate anesthesia for all our patients, whereas more than only 1/3 of the surgeons prefer topical anesthesia to peribulbar. In small pupils, subluxated, topical anesthesia may be avoided. Patients with topical anesthesia definitely have higher satisfaction levels, whereas peribulbar patients were more comfortable with peribulbar anesthesia in their second eye. 1/3 of the patients had to be supplemented of topical anesthesia with additional subtenon peribulbar or midazolam sedation. Well, only intracameral lignocaine can give good mydriasis, and the advantage is a good pupillary reversal in the post-operative period, but in hard cataracts, the pupil doesn't sustain. In phenylephrine allergy, cyclopentolate can be used instead of phenylephrine tropicamide combination. And in IFIS, intracameral epinephrine and viscotamponade can give adequate mydriasis in moderate IFIS. Omitting tamsuline and giving atropine really doesn't help in our experience, and Irish hook and pupil expanders probably are most effective and have to be applied before we have actually caused Irish trauma. Pupillary stretching is absolutely detrimental. Well, in comorbid situations, prostaglandin analogs may not be stopped before cataract surgery, but in India, because of the pigmented iris, we may require to stop it and give timolol and oral acetazolamide for 1 month before surgery. In lens-induced glaucoma, we can control IOP with intravenous mannitol, oral acetazolamide, timolol before cataract surgery. Arzolamide should be avoided as it interferes with endothelial pump function in the post-operative period, and all patients should be carefully monitored for steroid response because they already have a compromised trabecular meshwork. Well, with ocular surface disease and cataract surgery, we all know that cataract surgery aggravates and worsens the situation. So mild to moderate dry eye should be treated with lubricants. Meibomianitis should be controlled with tetracyclines, omega-3 fatty acids, and should be continued into and after the cataract surgery. NSAIDs should be avoided in order to avoid corneal melting in severe dry eye situations. As severe dry eye should be treated with cyclosporine, punctal occlusion as case requirements, and lubricants adequately before going in for cataract surgery. Well, trypan blue under air replaced by viscoelastic is absolutely non-toxic and non-toxically used to mature capsules. When we are using the premium IOLs, it may help us to perform a more consistent central round rhexis, which is so helpful to get a predictive ELP. And Viscoat is an adhesive, dispersive viscoelastic which best coats the endothelium, whereas Hilon 5 or GV can be used for tamponade when required in pediatric cataract, hypomature cataracts. They can be used to effectively to plug posterior capsular rents and can be removed because they can be easily removed. And a top coat of Viscoat really helps during the process of vitrectomy. If we give entire coating with Viscoat, to remove it after vitrectomy becomes difficult. So thank you for your attention. I think it was a big topic that I had to cover, and Dr. Amar had brought down the time, so I had to skip a little bit. Thank you very much for your attention. Thank you.